Acupuncture, for example, in certain instances have been shown to be beneficial. There's also increasing evidence that physical activity improves analgesia in patients with chronic pain. So in many instances it's antithetical, because patients feel if I move, I have low back pain, if I move it's going to get worse. Yet the data is showing otherwise. Proper sleep patterns. It has been shown that if patients are actually sleep deprived, the intensity of the pain is higher. And all of these are beneficial. Meditation practices have also been able to show improvement on outcomes in patients with chronic pain. The other thing that physicians should know and be aware too, because this can influence, is and why opioids are not the panacea for the management of chronic pain. Chronic use of opioids is associated with an enhanced sensitivity to pain, hyperalgesia. So you may have a patient on opioids chronically with a lot of pain that is the result of the enhanced sensitivity. So what do? You increase the dose and the pain gets worse. So there are instances actually where the pain can decrease when you taper down the opioid medication. There are several screening instruments, and unfortunately, as of now, we do not have sufficient scientific evidence to say whether they are effective or not. And this is because the studies haven't been done, not because they are not effective. The studies have not been done. And this is one of the conclusions that came around, and also is very clear with the CDC guidelines, because they very explicitly state there for this, we're recommending this, but even though the scientific evidence is not there. So this is an area where we need to have more research. We cover a wide variety of diseases of addiction and of drugs of abuse. So our focus on the opioids may be, say, 15 to 20% of our portfolio. And the other 80% of the portfolio deals with drugs like cocaine, deals with drugs like nicotine, which are extremely prevalent and have devastating effects, deal with issues of all of the synthetic drugs that we have, whether it's bath salts or cannabinoids. We do also work on steroids. We do also work on inhalants. So we cover all of the drugs of abuse. And opioids is one of them. Our institute is interested actually on doing research that relates to the three approaches that the Health Secretary, Sylvia Burwell, has brought up as the strategy of HHS to combat the opioid epidemic. One of them is better prescription practices for the management of pain. The second one is extended access to naloxone, which is a medication that we use to counteract overdoses from opioids. And the third one is expanded access to medication treatment for opioid use disorders. On the first space of better prescription practices, the Institute is engaged in helping develop research that would lead to analgesics that don't have abuse potential and those don't produce addiction. The Institute is also engaged on helping pharmaceuticals develop abuse deterrent formulations. So we're working on those spaces. And we also do research into basic science, neuroscience, of what happens. Why does someone suffer chronic pain? Why someone suffers chronic pain and another person not, even though they have exactly the same insult? It's just like with drugs. Why does someone become addicted and another person does not? So basic science on understanding that. Another strategy, very important in the whole management of pain, is development of better biomarkers. So if I want to know if someone has pain, the only thing I have right now is ask you the question, how much pain do you have from 0 to 10? And that's subjective, and it does not really tell you much about the underlying causes in your brain that are leading you to that perception. So we are investing research to develop it in areas of the use of imaging, for example, to be able to get biomarkers. And we're trying to create partnerships with pharmaceuticals for this purpose. This is something, of course, we do with many other institutes at the NIH.